much. Right, so Michael, it's sort of light-hearted, I think quite fun, and for those of you that can put up to the end of the talk, there's some really interesting videos from an anaesthetic ICU perspective. So this is the Northern Lights on the BBC website a few days ago, which I thought, oh, isn't that lovely? Okay, so let's start with the first randomised controlled trial. And, you know, clearly a lot of practice is done on the right. You know, we just do the same thing over and over again, but we keep on doing it, and experience tells us that we're more confident doing so. And in honour of Hannah, you know, she's a clinical epidemiologist, you know, so she randomised her siblings accordingly. Okay, first randomised trial was James Lind, the father of naval medicine. And it's a really lovely thing. You can download it from the web, and it's actually really interesting to read. And clearly, scurvy was a big problem in the Navy 400 years ago, or even before then. And obviously, the Brits found the answer, Lind found the answer, among others, as you'll find out. And that's how we got the name Lineys from the Americans. And at the time when Lind was looking into this, there was lots of speculation as to why. Could it be the salt diet, a lack of oxygen in the body, fat skin from the ship's boiling pans, bad air, thickening of the blood, too much sugar, melancholy? And a lot of text, but basically I've translated it from old English to more modern text, or more modern font at least. And basically, he endeavoured to say, let's see what the evidence shows, and put aside all systems and theories disavowed by nature and facts. Where I have been necessarily led in this disagreeable part of the work to criticise the sentiments of eminent and learned authors, I've not done it with a malignant view of depreciating their labours or their names, but from a regard to truth and the good of mankind. I hope such motives will, to the candid and the most judicious, be a sufficient apology for the liberties I've assumed. He was worried, and as you'll find out later, he did upset people. And basically, he went through the description of the disease, the causes, how to prevent and cure it, upon facts and observations without suffering the illusions of theory to influence and pervert the justice. And he got together 6 pairs of sailors and in the scurvy, and they were put in a proper apartment for the sick, a ward on the ship, or the ship's hospital bay, and they all had a common diet, and some of which I think, oh, I couldn't mind eating that, and some of which I think, not really, but every day it'll get a bit boring. Anyway, he then randomised them, and 2 were ordered a quart of cider a day in addition. 2 got elixir vitriol on an empty stomach, I think to make them sick. 2 got 2 spoons of vinegar 3 times a day on an empty stomach. 2 had to drink half a pint of seawater a day. 2 got a piece of garlic, mustard seed, horseradish, balsam of Peru and gum myrrh 3 times a day. And 2 got 2 oranges and 1 lemon. Now, you weren't given a choice as to which group you were put into, but give me the cider, please. And basically, you see, the consequence was the most sudden and visible good effects were perceived from the use of the oranges and lemons. Actually, cider came a close second, you'd be pleased to hear. One of those who'd taken them being at the end of 6 days fit for duty, the other was the best recovered of any, and being now doing pretty well, was appointed nurse to the rest of the sick. We should do that with our ICU patients. Okay, you're better, look after the bloke in the next bed. But it took 42 years. Lind was well dead by the time it got adopted by the Royal Navy. Why? Well, conflicting opinion. And one of the people who competed with that was no other than James Cook, Captain Cook, who obviously discovered the east coast of Australia, etc. What did he believe in? Basically, he believed in sauerkraut. You may laugh. And there it is on the ship's roster of what they carried. You can see here they took lots and lots of sauerkraut. And spelled slightly different to what we do now, but sauerkraut, pickled cabbage. And basically it works. And I found this, 1929, the Journal of Agricultural Research, where they actually showed that, yep, there was some belief that sauerkraut must contain vitamin C, because it was used as an old age therapy on long sea voyages, and scurvy didn't appear in regions where people ate lots of sauerkraut. And the fermentation process of cabbage actually generates vitamin C. And they did some experiments in guinea pigs, and basically they gave them a scurvy diet and basically found they were ill and they lost weight. But then when they introduced the sauerkraut, you can see things got better. So good for sauerkraut. We may laugh, but what about serendipitous observations? This guy, Larry, was the surgeon for Napoleon, and he went on his campaigns with Napoleon. And this is a lovely story. There's this came out, the campaigns and voyages, 1815 to 1840, and this is the sort of text that goes with it. And he noted that cold is only the predisposing cause of gangrene, which manifests itself in such cases. He argues it's how quickly you reheat the cold digits that actually causes the problem. And he made the observation on the night of the 10th of February, when the temperature was just 5 above zero, lots of soldiers of the guard and of the line complained of numbness, tingling and pricking of pains in the feet. Those who, while the cold lasted, warmed at the fire, the diseased part saw the gangrene declare itself on commencement of the thaw. Those, on the contrary, who rubbed the affected parts with snow and afterwards with camphorated brandy were preserved from gangrene. Because you've got ischemic limbs, the blood vessels all shut down, you try and warm it, you increase the metabolic rate, you just make it worse and increase the degree of injury. And so, again, when we have our ischemic fingers and toes on the ICU, the natural tendency is, oh, we need to warm them up. No. The last thing you should do is directly warm them up. You can try and warm up the other limb if it's not affected to get reflex dilatation, but you shouldn't do direct warming of ischemic digits. But Larry got there first. What about one observation leads to another? This guy said the seemingly useless or trivial observation made by one worker leads on to a useful observation by another, and so science advances, creeping on from point to point. I'll leave you to Connor to advance from, oh, there we are, go from point to point. Okay, so I'll pick on Alexander Fleming. Do you know the story about Fleming? Basically, he was a fairly useless microbiologist, and apparently he only got the job at St Mary's because he was a good shot, and they needed him for the shooting team. In those days, that's how you got your jobs. Anyway, he went on holiday, and apparently he was a bit of a messy researcher, and he didn't wash up. The Petri dishes were in the sink, the window was open, spores flew in through the window, and when he got back, he found blue mold was growing in one exposed Petri dish and killing the surrounding bacteria, and that's the picture. So it was an N-of-1 experiment, and he identified this as a penicillin species. He actually got the wrong one, but that's another story, and he named it penicillin, and he reported it as a sort of small paper in the British Journal of Experimental Pathology in 1929, and then basically forgot about it. He thought, well, this is interesting, but so what? And so did nothing about it. And then the story got picked up by Chain and Flory in Oxford, and they picked up this paper and thought, well, we might actually use it as an antibacterial. Sulfonamides had come in by then as an antibacterial, and so they thought, oh, what about penicillin? And they worked out the chemistry, they purified it, they did some very nice trials on mice, and the first patient was treated on the 12th of February 1941. It was a policeman who'd basically got septic from, he scratched his mouth, inside of his mouth, from a rose thorn and got lots of abscesses, and he was very sick. And they gave him penicillin. Within 24 hours, his temperature fell, his appetite returned, the wounds began to heal. The trouble is that they didn't have much drug. They ran out on day 5. They were actually collecting his urine to try and recycle the penicillin, but that wasn't enough. He got worse and died. Treatment was a success, however. And obviously, they went to Fleming because they thought it would give him the honour of trying it on the first patient. And then Flory went to the US. This is during the war, and we're talking about, you know, the vaccines and now with COVID. But look what they managed to achieve in the Second World War. So they went to 3 big pharma companies, and they went from 21 billion units, and that's a hell of a lot, in a couple of years. And they by 1945, they were into the trillion. So again, you know, just shows when there's a crisis how things can happen at pace. Quite impressive. And clearly what happened to Fleming, fame and fortune? He got knighted, he co-shared the Nobel Prize for leaving the window open, and he became the rector of Edinburgh University. And clearly, again, one observation leads to another. So apart from obviously being treated for war injuries, oopsie daisy. Sorry?
Move it right. Let's just go on to the screen.
Oh. Click the wrong one. There you are. Other infectious diseases were also cured.
Same again.
Same again. Oh. Okay. Okay, let's talk about fluid. Because when you hear people talking about fluid historically, everyone talks about Dr. Latter. So Dr. Latter was a doctor working in Leith near Edinburgh. And at the time, there was lots of cholera outbreaks in the UK. And this was one in Edinburgh in 1832. And he wrote a letter to the Lancet, basically talking about giving intravenous saline. I've never seen one bad symptom attributable to it, and I've no doubt it will be found when judiciously applied to be one of the most powerful and safest remedies yet used in the second stage of cholera, or that hopeless state of collapse to which the system is reduced. So that's the slide people show. Look, vindicating the use of intravenous saline. Right click, is it?
Right. Left is fine. Left is fine. Yeah, right.
Sorry, might be, yeah, sorry. Which one? That one?
Yeah, that one.
Okay, great, thank you. However, just a few months later, he wrote back to the editor, if you could spare a corner in your valuable paper, please give publicity to what follows. Hitherto, those who have deemed, including him, saline venous injection a remedy worthy of trial have often been disappointed in consequence of the evanescent, the short-term nature of the good symptoms produced by it. To render those more permanent appeared to me a mighty desideratum, highly desirable. Hitherto, such has been aimed chiefly by repeating the remedy. Let's give more saline. Incredible quantities have been used, and I have no doubt sometimes evil consequences have been the result. Hey, been there, haven't we? Let's just move on a bit. Ringer, University College London, Professor of Medicine here at the hospital. And again, serendipitously, he discovered Ringer's solution. Well, actually, it wasn't him. It was his lab technician, because the lab technician was too lazy to actually make distilled water, so just got tap water. And the tap water that supplies this area of London is from the New River. And basically, he was doing experiments on heart muscle and contractions, and they weren't working. And then all of a sudden they started working. And then the lab technician fessed up that he'd been a lazy so-and-so, and whoops, it's got lots of impurities. And that's what he found, especially the calcium did the trick. And then Ringer's solution actually got adopted as an intravenous fluid for use in patients later on. And this is 1883. Let's move on a little bit further to 1918, and that man there is also University College London, but it's a guy called William Bayliss, who was a professor of physiology. He was the brother-in-law of Starling, who was also here, and they often did stuff together. And this is a lecture he gave on the intravenous injection of fluid in wound shock. This is during the Second World War, and as you can see right at the very top, Ringer's solution, although naturally one of the first to be tried, has been found to be useless, both experimentally and in actual practice. It leaves the vessels in the course of half an hour or so, while the blood pressure returns to its former level or even lower. Oh dear. Perhaps he had a vested interest, because this is work he did a few years ago. He found addition of substances such as gum arabic or gelatin to the extent of 5% added to the Ringer solution considerably improves its efficacy in restoring a low blood pressure. Such an addition raises the viscosity to somewhere near that of the blood. Again, I'm happy to give any of these papers if anyone wants them, but they're actually all fascinating read. You can see how the fluid debate just goes on and on and on. And again, another lecture, but there's loads of stuff about blood and fluids, etc. Okay, a little bit about cardiac, just a heartbeat away. again, we think, oh, things have been around for ages. They haven't. So this guy, Paul Zoll from Boston, look at what he developed. First pacemaker in 1952, first cardiac monitor in 1955, and the first external defibrillator in 1956. What did they do beforehand? Good question. Massage. So the first modern day description of closed chest cardiac massage, as demonstrated here, came in JAMA in 1960 from this lovely term, Kuvenhoven, Jude and Knickerbocker. And that's from the paper, and they've used it, the technique, in 20 patients with an overall permanent survival rate of 70%. So they now could defibrillate, and in the old days, they had literally, doctors carried around a pair of big scissors in their pocket to do a thoracotomy and put their hand in and massage the heart. That's what used to be done. And now they said, well, you perhaps don't need to do that. You could do cardiac massage, and they showed there what blood pressure you could generate in one such patient. Again, this wasn't the first. It had already been published. This is Koenig was a surgeon in Germany, Göttingen, and he published in 1892, because at the time a lot of people were dying from chloroform anesthesia. They were going into VF. And basically he reported cases where you gave external cardiac massage. Sometimes they lived, but if you can got them back quickly, they then survived. And he was going at a rate of 40 a minute, and then one of his juniors then repeated it, but going at 120 a minute, and found the outcomes were perhaps a bit better. He wasn't the first either. Again, this guy is a Hungarian called Balassa. I think he was Hungarian. And I'll just read the story. It's a lovely story, translated from the original Hungarian or whatever. She lifelessly collapsed. Her tense shoulders and arms became flaccid. Cyanotic face became a mask of death. Her chest didn't move anymore, and the pulsation of her arteries and heart ceased. At the same time, I exerted bellows-like rhythmic pressure to the front of her chest, imitating breathing. While air entered the lungs with a sharp whistling sound, I splashed quickly fresh water into her face, held a vinegar-dipped cloth in front of the opening on her tracheostomy tube. Close to 6 minutes passed without her moving at all, without the slightest signs of life. With my hopes lost, I was close to stopping when she rejoiced me with a hasty and spontaneous sigh-like inspiration, supported by the movements of my hand. This was followed by a second and third breath, and from the struggle of death, life began to smile at us. Oh, isn't that lovely? How poetic. Nearly finished. Few slides, a couple of videos. Great myths of our time. There are lots of myths. And when you get told off by an infection control nurse and ask for any evidence, they always say Semmelweis. True? If you haven't washed your hands. Semmelweis. And when you ask them anything more recent, they go, there must be. And you go, well, Semmelweis was a long time ago. So let's have a little look at Semmelweis. 1847. So again, there's a translation of what he wrote and a sort of introduction. And basically, he got onto the case because one of his colleagues, he was an obstetrician gynecologist, died. And he basically worked out the cause was the guy cut himself from a contaminated autopsy knife. And at the time, you know, Pasteur hadn't come along for another 20 odd years. And so he thought it was the introduction of decaying organic animal matter. And he realized that students and others, after washing with ordinary soap and water or without washing at all, were examining the maternity patients. The smell of their hands convinced him that washing in the ordinary fashion wasn't good enough. It didn't remove this decaying organic matter, which had become sort of contaminated in the dissection. So these women dying of puerperal fever, because the idea is the students, that's what we're taught. Oh, they didn't wash their hands. They went and delivered the babies. The women got puerperal fever, strep infections, and died. And he made them wash their hands and things were better. But how did he make them wash their hands? So, as I said, he felt it was decaying animal matter, and this is what he did. You have to oil them before they're contaminated, so the decaying matter can't penetrate the pores of the skin. Thereafter, you have to wash the hands with soap and then expose it to a chemical agent. So he employs chloride of lime and wash as long as necessary to make the hands slippery, and then hands in this way are completely disinfected. So it's a bit more than just a splash of alcohol gel, isn't it? Do you know what happened to Semmelweis?
He was laughed out.
He was laughed out, and this is what he wrote. I'll later cite numerous professors of obstetrics who've written against my teaching. Only a fool could believe that students who have been taught so fallaciously will disinfect themselves as conscientiously as necessary. And when death reaps a rich harvest, the failure of chlorine washing is cited as evidence for the epidemic origin of childbed fever. So he was doing this work in Vienna, and he got drummed out and went back to Hungary, Budapest, and he went a bit crazy because I think he felt misunderstood, and he was admitted to a lunatic asylum, and he got beaten up by the guards soon after he got there. I think his hand got cut, he got septic, and he died. Oh, shame. Okay, weird and wacky, last bits of the talk. Bringing back the dead. So I'll play this in a second. So this is 1940, if I remember. Russian. Have you got volume on this?
Should come out of speakers.
Oh, lovely. Let's hope. So the guy introducing it is a guy called JBS Jack Haldane, who was professor of biometry at University College London. And he was an incredibly brilliant man and did loads and loads of things. And he was a real avowed socialist, and he loved Russia. And so he did the intro for this speech, for this clip, and I've edited it down. It's about 30 minutes long, but I've edited it to a couple. Hopefully you'll get I think there's sound in a minute, but I think that the beginning, there's no sound. 1940. Oh.
Actually carried out, I should like to tell you that I have seen some of the experiments shown in this film actually carried out reviving the whole organism. The revival of the whole organism can be achieved with the help of an apparatus called the auto-ejector. No interruption of the animal's normal functions has yet occurred.
The dog there. Sanguinate the dog.
The heart has stopped. This is one of the animal's last gasps. The dog is dead. The venous pump is connected with the vein. 10 minutes have elapsed since the animal died. The artificial blood circulation gradually induces the heart to start beating again. The heart's action begins to be normal. First sign. We can now disconnect the auto-ejector and leave the organism of the dog to maintain life with its own resources.
And there are some more gruesome bits on that video that I won't, I'll spare the audience that, but hey, interesting. Reanimation after death. This came out 2019 in Nature, good journal. And basically this group in the States did the same with a brain, intact pig brain, and they basically left it dead for up to 4 hours, and then they basically reoxygenated it with special fluids and blah, 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 and basically found preservation of architecture, attenuation of cell death, restoration of normal sort of responses, synaptic activity and active metabolism. So there, that was after a sort of up to a 4 hour. They didn't actually have it connected to the rest of the animal at the time, but hey, rediscovering the wheel. Last bit of the talk, good job they didn't have ethics committees in the good old days. So resuscitation. So this guy here is like the godfather of resuscitation, a guy called Peter Safar. He came from, I can't can't remember, Czech Republic or Hungary, but he, and around the time of the war, he came, Austria, was it Austria? Thank you very much, to the United States, and he worked in Baltimore, and then he went to Pittsburgh. And he came up with the notion of ABC. And I'll show you a little video that he did from when he was at Baltimore.
The experimental study you are about to see is one of 18 similar studies during which we compared various methods of artificial respiration. By anesthetizing and curarizing these subjects in order to simulate limp asphyxia victims. Now the subject is being rendered unconscious by the intravenous injection of 1 milligram of scopolamine and by several doses of meperidine. Now succinylcholine, a curare-like agent, is given by continuous intravenous drip. All muscles, including the respiratory muscles, will remain paralyzed for the next 3 hours. With these optimal airway conditions, you can see that the spirometer indicates tidal volumes of 280 to 340 milliliters.
These are healthy volunteers.
Unfortunately, in 2 of our 9 subjects studied with this chin-up position plus an airway, all tidal volumes were smaller than the estimated dead space air. Now you will see the most effective mouth-to-mouth method for use in adults. We call it the thumb jaw lift method. Note the hand positions. The mandible is grasped at the midline with the left hand and pulled forcefully upward. The pneumograph shows tidal volumes of 2,000 milliliters and more. This S-shaped breathing tube, also called mouth-to-mouth airway, made mouth-to-mouth breathing more aesthetic and more effective. A large airway for use in adults and children. First, the airway is inserted. One hand forces the mouth open, the other hand inserts the airway over the tongue, taking care not to push the tongue back into the pharynx. The rescue prevents air leakage through the nose and the corners of the mouth. Either this way. We studied the performance of portable resuscitation equipment in the hands of untrained rescuers. They performed on paralyzed volunteers. Tight mask fit. This Boy Scout will perform mouth-to-airway breathing. He weighs 100 pounds. He has some difficulty, but corrects himself. He was able to adequately ventilate subjects weighing up to 210 pounds. 87 untrained rescuers performed mouth-to-airway breathing. All produced breaths larger than 500 milliliters within 60 seconds after one demonstration. All could insert the airway within 40 seconds. With mouth-to-mouth breathing, reoxygenation can be accomplished within seconds by deep inflations through an open airway.
So, sorry, I'll go back. Last slide. Finished with Haldane. So, theories of 4 stages of acceptance. It's worthless nonsense, interesting but perverse point of view. This is true but quite unimportant. I always said so. Thank you for listening. Well, probably you all need a drink after that. Can we put the lights on? Any quick comment, question? As you see, it's fascinating, actually. It's just, I've got loads and loads and loads like this, and it's just really interesting that somebody's thought of it before and it's just got forgotten about. You know, and then it's rediscovered, and then we go, oh, look at this. But hey, any final comments, anyone?
So how would you stop that?
What?
Rediscovering the wheel.
Well, actually, in a way, what you need to do is get old farts like me who get more and more, the older you get more interested you get in history, and sort of look back and think, oh, look, you know, and then there's probably lots of other things, you know, there's lots of other, you know, I could give you loads of other examples. One of the ones which I almost gave today, but I didn't, but I'll mention it briefly, was the Lancet 1867, the first description of amyl nitrite for angina pectoris. And the guy was a physician who did some work, 3 years of his life at UCLH. And he thought, this is very good. And he worked out, because a chemist who also worked at UCL had tried it on himself, a guy called Guthrie, and found he'd got like throbbing, pulsation of the arteries, throbbing headache, etc. So he thought, actually, it might be a good idea for angina, because he thought having too high a blood pressure was bad for you. And so he, describes giving it to some angina victims with great effect. And then he goes on to think, well, it worked in angina, I should try it in cholera, because they're shut down, and therefore maybe with their collapse, he hadn't worked out, maybe they needed just some fluid, that maybe dilating them up might help for cholera. Interestingly, in that paper, they tried on one of the patients digitalis, digoxin, something called, which is, I've forgotten the name, the botanical name, but it's a lobelia, which is known as queen of poisons. That didn't work. And another one, which is called pukeweed, or Indian tobacco, which is used as a sort of antiemetic and basically scares away mosquitoes from your tent. Cherokee used it, so that didn't work. So he thought, let me try amyl nitrite. So there you go. So there's probably a lot of these things in the literature where somebody had the bright idea, reported it, and then it's got forgotten about. It's just out there waiting to be rediscovered.
Do you have any idea how? So you go back to 17 something or other, so fairly recent history of pipes. Any idea if you go all the way back, medieval, ancient Greece? I mean, I appreciate the documentation probably wasn't great, but there was a whole lot of herb stuff, wasn't there?
Yeah. Well, Simon Cohen, who many of you who are old enough will remember, he was a physician here who was in the intensive care unit, but there was a guy who was interested in Babylonian history and had tablets that they found in Babylon, and this guy translated them, and Simon was the medical opinion, and there was that treatment of bladder stones and stuff like that. So it was there, and Simon did all these translations for the guy, and they got published somewhere, I can't remember where. But yeah, you're absolutely right. And how they crushed the bladder stone to help the person pee.
Sort of a historical medical research,
Yeah.
All the old therapies again.
Livers in jars.
Yeah, well, mercury. We try mercury with you again? No?
Pardon? Mercury.
Penicillin stopped working. We'll try the mercury.
And the lithium. It worked as well as the lithium. Okay, on that note, thank you very much. We've run 10 minutes over, but thank you all very much indeed for coming. And thanks, Hannah, Riaz,